Hello, everyone. Welcome to episode 90 of the Good Mood Podcast. It's a landmark episode. We are 10 short of 100 episodes since I started this podcast in mid-2020. Today, we're going to talk about neurodivergent-informed therapy. And so we'll talk about what neurodivergence is. This is a solo episode to celebrate number 90. I know it's been a while since I've recorded an episode, but one of the reasons that I am behind on podcast recording and they're coming in less frequently is because I'm doing, as many of you know, and many of you may not, I'm doing a master's degree in counseling psychology at Yorkville University. And I've been doing it for over a year now, and I have almost a year left. I'm finishing up my coursework. I have another term and a half of coursework, and it's in September of 2023. I'm going to be starting a practicum. So in addition to my naturopathic practice, I'm also going to be completing a psychotherapy practicum. So if you live in Ontario, stay tuned, because there'll be an opportunity to, if you would like to work with me in the capacity of a psychotherapy client. And very likely it'll be a reduced rate, as I will be in a registered psychotherapist qualifying. So stay tuned. There'll be more information on that, but I will be working with a clinic called In Wholeness that provides online therapy. So for my last course, I wrote a paper called Counseling Neurodivergent Adults in Canada. So I did a lot of research on neurodivergence, and I thought that I would share that article, share this paper as a podcast, because I thought it might be interesting, because as you will learn, 15% of people in the world, so 1 to 2 out of every 10 of you listening may identify as neurodivergent or maybe neurodivergent. And so this might be relevant for you to listen to and to learn more about. And for the sake of avoiding self-plagiarism, I'm going to, be tweaking this article a little bit, expanding on it, and giving it a little bit of a naturopathic spin by talking about some nutritional interventions. So I hope you enjoy. This is a little bit different from what I normally do. It's quite academic. I'm not going to be citing or reading out the references or citations. If you want the citation or reference list, I can share that with you. But there's a very interesting researcher called Monique Botha, who writes a lot about, she's an autistic researcher, writes a lot about neurodivergence and neurodivergent therapy. So you can always check her out on Google Scholar or PubMed. So the neurodivergence movement recognizes conditions such as autism and attention deficit hyperactivity disorder, or ADHD, as identities or biological variations in human behavior and cognition, rather than mental disorders or illnesses. So in this podcast, we're going to explore the demographics of neurodivergent adults in Canada, examine specific mental and social health challenges that neurodivergent individuals face, and we'll apply a counseling lens to it, considerations for counselors, but also for clients, patients, you, the public, who are neurodivergent. What should you seek in terms of counseling, or what information may be beneficial for you, but also people providing care to neurodivergent individuals, especially counseling care. So this may be is hopefully applicable to everyone. So some background is 600,000 adults in Canada are neurodivergent, and it's about 15% of the world's population. Neurodiversity or neurodivergence, they can be used interchangeably. I'll be using them interchangeably for the purpose of this podcast. They encompasses attention deficit hyperactivity disorder, ADHD, autism, and other conditions like dyspraxia, dyslexia, dyscalculia, and Tourette syndrome. And the term neurodiversity was coined in the 90s by Judy Singer and Harvey Bloom, and it became popular discourse or popular terminology in the online autism community. And neurodiversity refers to the variability in human brain structure and cognitive function that reflects the natural biological diversity inherent in most species and essential for their survival. So just like some people have blue eyes, some people have brown eyes, some of our brains work differently. And this is thought to be, rather than a disorder, there's so many people in the population that are neurodivergent that it's likely a normal variation in our cognition that conferred some sort of benefit to our survival. And so neurodivergent, this term refers to individuals whose cognition varies from the standard or the majority. And so in many cases, neurodivergent, neurodiversity, those are interchangeable. Neurodivergent, it refers to the individuals. Neurodiversity refers to the spectrum of diversity in neurological and cognitive function. But we can use them. I'll sometimes say neurodivergent individuals, neurodiverse individuals. I'll use them kind of interchangeably. And in the literature, I was finding that they were used interchangeably. And in this paper, in this podcast, I'm going to talk about autism and ADHD preferentially, because those are probably the more common neurodivergent conditions or neurodivergent states. So autism is, we'll start with talking about, it's viewed, can be viewed through various lenses. So for many years, and even currently, it can be viewed through the lens of developmental psychology. And it refers to an innate lack of the ability or desire to engage in the social world. When viewed through the psychiatric lens, it's a disease, disorder, dysfunction, or otherwise deviation from the norm, which requires prevention, medical management, and cure. And this is often how psychiatry views various diagnoses, right? This is often how the medical system views various states, right? And this is often beef that we naturopaths have, and biopsychosocial counselors as well, in that just because there's deviation from the norm doesn't mean that there's an impairment in function, there's something wrong or pathological with the individual, but that maybe it's the societal landscape that is a mismatch, an evolutionary mismatch for the individual. And so, often with psychiatry, there's this normalizing lens, this pathologizing lens that gets applied, and this has been applied to autism, even currently is applied to autism, right? So the DSM-5, the Diagnostic Statistical Manuals, this is like the Bible of psychiatry. It lists a set of observable autistic behaviors, such as impairment in communication and socialization, and restrictive and repetitive behaviors that always have a childhood onset. Nobody exhibits these types of behaviors or symptoms later on in life. They're usually, if we're considering that it's a genetic condition, genetic neurodivergence, then these are going to be present in childhood. Now, there's a more current, more modern, more from the neurodiverse landscape or lens. There's a lens called the deficit is difference. And this is endorsed by the neurodivergent community, which we will get more into. We'll talk more about the neurodivergent community. But through this lens, autism is considered a biologically determined variability in normal human cognition and social function. And so that's quite different from this pathologizing lens. What this deficit is difference implies is that we're born with these differences in the way that we interact with the world, the way we interact socially, the way we interact cognitively. And these may confer different behaviors, mannerisms, ways of interacting with the world. And they're not pathological. They're not necessarily bad. They might interfere with how we're accepted socially or how we engage in a society that's set up for a neurotypical population. But this doesn't mean that there's a pathology or an issue. And so what is often inherent in these biological differences are, certain difficulties, especially when faced with a neurotypical society, but also gifts. And so when we can look at neurodivergence in this way, it allows us to see all of the parts of the individual and how their mental health, how their social health interacts with the environment that they are raised in, that they're working in, that they're being educated in. So autism has various features, such as alexithymia, which is defined as an inability to articulate or sense one's emotions. decreased executive functioning. I talk about this a lot in various podcasts and on Instagram, but executive functioning is the ability to plan, manage, organize, and execute tasks. And so one of the characteristics of neurodivergence is that individuals have difficulty with executive functioning. Other features are social skills deficits and information processing delays. These features may be considered disabilities whenever they interfere with the autistic individual's integration and acceptance into a fast-paced social world in which their neurotype is the minority. Right? So if you are in an environment in which you're expected to process information quickly, display high level of executive functioning, then there's going to be a deficit that you experience, difficulty. In a highly social sensory world, this is often where autistic individuals encounter difficulty. And the features of their neurodivergence may be considered disabilities. There's much overlap between the symptoms of autism and ADHD, and anywhere from 30 to 80% of autistic children also meet the criteria for ADHD. So ADHD is a multicultural, bidimensional concept. Okay, this means that all cultures, right? And this furthers the argument that it is a genetic condition, that because it's present in all cultures, so it's not culturally developed. So all cultures have, including hunter-gatherer societies, have individuals that have more of it, that display signs of ADHD. And it's bidimensional in that it involves both inattention and hyperactivity, and the symptoms, just like autism, start in childhood. The inattention symptoms are more strongly associated with deficits in executive function, academic underachievement, and social symptoms such as shyness and social withdrawal. And often individuals with ADHD are highly intelligent and yet find that they are inconsistent or underachieving in school and work because of this inattention dimension in the way that their cognition works, in the way that their brains work. And hyperactivity is associated with injuries, social problems related to disruption, aggression, low self-control, and impulsivity. And so this may include like interrupting people, impulsive behaviors, hyperactive behaviors. You can imagine how that might be related to injury. This is often what gets noticed in the classroom in childhood. Women are often diagnosed with autism and ADHD later in life, despite symptoms originating in childhood. In adulthood, the ratio of males to females with ADHD shifts from 3:1 to 1:1. And so we have, for every 3 males child males, boys with ADHD, there's 1 girl who's diagnosed, but in adulthood that shifts to 1:1. So there probably isn't a gender difference, but only that it gets underdiagnosed in girls. So this means, and put another way, many timely diagnoses in women are missed. And this is further impacted because many neurodivergent women learn to mask their autism or ADHD, and we're going to talk about masking, by forcing themselves to make eye contact, communicate with gestures, overachieve at work and school. So they put in extra effort to mask, hide, overcompensate for their symptoms of the features of their neurodivergence. And so often they appear neurotypical. And so the diagnosis is mixed, or no one is flagging them for a diagnosis. They're also maybe leaning on the more inattentive type if they have ADHD, and therefore they're not really noticed by their teachers because they're not overtly or explicitly disruptive in class. So the inattentive form of ADHD often gets missed or underdiagnosed or not diagnosed till later in life, when people start doing their own research, advocating for themselves in a healthcare setting, because it's less visibly disruptive, and we call it phenotypically noticeable. Phenotype is the expression of your genetics. So, I can dye my hair blonde, but I have genetics for brown hair. So the phenotype is what gets expressed. Many professionals, unfortunately, are unaware of the autistic female phenotype and the specific characteristics of autism in females. And so many diagnoses are missed until women who suspect they're neurodivergent advocate for their own assessment. And this is often later in life, after having many experiences of maybe not fitting in, underachieving at work and school, having issues with work, and then, wondering, perhaps externalizing the problem. Maybe this is something to do with the way I'm interacting in this social environment. Maybe I'm autistic, and then advocating for a diagnosis and learning this, as adults. Autistic women have higher rates of anxiety, mortality, and incidences of sexual assault in their lifetime than their neurotypical peers or their autistic male counterparts. So this is worth noting, that there's further considerations for women with ADHD or autism. There's also a connection with gender identity and autism or neurodivergence. So transgender and gender diverse individuals self-report more autistic traits, such as systematizing, so being very particular and needing to work in systems, boxing in one's environment, sort of grid-like thinking, sensory sensitivity, and lower empathy than the average. Transgender and non-binary people are 3 to 6 times more likely to be autistic, and autistic individuals are 7 times more likely to experience variance in gender identity. So there's this sort of Venn diagram in terms of being gender diverse and neurodiverse, and it which tells us that there likely isn't it's not that one causes the other, because you see both. You see transgender individuals, gender diverse individuals are more likely to be autistic, and autistic people are more likely to be transgender, gender diverse. So there's a big chunk of the population in the middle of that Venn diagram that are both. And so, as counselors, we should be aware of the prevalence of neurodivergence in gender diverse individuals and vice versa. And in this way, we may tailor therapeutic approaches, improve access to healthcare. It's difficult to advocate for one's healthcare, to really explore gender identity when these things are sort of conflated, when an individual who's gender diverse may also wish to explore a diagnosis or an assessment for autism or ADHD to enhance self-understanding. The neurodiversity movement is worth talking about. It upholds the notion of disability as an interaction between social factors and personal deficits. Neurodivergence is a valid variation in what it means to be human, rather than a disability or disease to be treated. And this is very important, because positively identifying with an autistic or neurodivergent identity may support self-esteem and protect one's mental health. And it's also important to note that an official diagnosis is not necessary to identify as neurodiverse, and to be part of the neurodivergent movement or neurodivergent community. And many people in the community, whether it's cost or inability to access an assessment, don't have a formal diagnosis. But through reading, through understanding the symptoms, the features, through connection with the neurodivergent community, they're like, okay, I really identify and feel like this is how my brain works. Now, symptoms of neurodivergence are often intertwined with an individual's attempts to adapt to societal ideas of normalcy. And so, according to the neurodivergent movement, the distress that a neurodivergent individual experiences results from the conflicts between the individual and their neurotypical environment. And this includes societal barriers they may face, such as lack of acceptance, bullying, social deficits, and not from personal medical problems and abnormalities. And so this is important, right? So this idea in the neurodivergent movement, they do generally, according to the literature, according to what I read, that the idea of disability is accepted. It is considered a disability, but a disability, importantly, is framed as an interaction between the individual and the environment, rather than, so if all humans could fly, it would be considered a disability if you couldn't fly, especially if our society was geared towards flying humans. And so this is the idea that in a neurotypical world, in a sensory social world, having neurodivergent traits creates a deficit in the individual. And so it's about this interaction between society and the individual. So therapy that supports neurodivergent individuals aims to bolster the subjective well-being of the neurodivergent individual and promote diverse and adaptive functioning that society may view as atypical. So the idea is not, so from the psychiatric lens, it's like this is a deviation from the norm, and so we have to shift the individual to fit the norm. The neurodivergent movement disagrees with this wholeheartedly. The goal of therapy is not to fit the individual into the mold that society dictates, but to allow the individual to adapt, find their place in society that honors their particular gifts and individual features. And it reminds me of that quote by Jiddu Krishnamurti: "It's no measure of health to be well adjusted to a profoundly sick society." So this is not mental health. Just fitting an individual, like the Procrustean bed. The bed of Procrustes is like chopping the person's foot off to fit in the bed. That's not mental health. That's not health. We want to adjust the bed, figure out how to, gain accommodations, how to support skills, how to address issues that a particular individual may be facing. So behaviors like avoiding eye contact or repetitive body movements, these are most likely unharmful to the individual and to others, and therefore should be just viewed as, individual features, possibly even coping mechanisms. And they shouldn't be pathologized. They don't need to be corrected. They don't need to be repressed. And so therapy and medicine, I argue, should avoid pathologizing the individual, and it should avoid trying to impose neurotypical ways of being on the neurodiverse individual. And so this neurodivergent movement, it's asking for more neurodiverse voices, lived experiences in academic research, clinical spaces, and popular discourse. And we are seeing more with the online world, with a focus on tech and technology and more technologically based industries. We're seeing in entrepreneurship, we're seeing sort of this rise in an acceptance and in a reverence for neurodiverse traits, which now there's more room for in society. Whereas before, society was largely like industrial, factory work, like repetitive, like not a lot of creative work. So there's also language considerations. So you might hear me mostly saying things like autistic person or autistic individual. So according to research, according to the current research, the neurodivergent community, neurodivergent individuals largely favor identity-first language. So language that says like autistic individual, autistic person, autistic woman, as opposed to person-first language like person with autism. And this is interesting to me because we, are very often trained, especially from a narrative therapy lens, to say something like a person with anxiety, not an anxious person, right? Because by saying anxious person, you are ingraining that feature into someone's identity. It's different with neurodivergence. And in fact, the community largely recognizes that person-first language, so saying person with autism, it pushes more on the side of stigma because it implies that autism can somehow be removed from someone's identity, right? And so it's very different from something like anxiety, where we want to say a person with anxiety because we're all anxious. It's not like you can completely remove anxiety from someone's life, because anxiety is a natural reaction to a dangerous, life-threatening, stressful circumstance. But when you say person with anxiety, you're allowing there to be space between the individual's identity and the anxiety. But doing that with something like autism may actually reinforce stigma, because you're saying, well, you could live without the autism, or you could be closer or further away from autism. But but in the neurodivergent community, we're saying that neurodivergence is a genetic, biologically determined variation, and therefore, it's as ingrained in someone's identity as like saying that you're Canadian, right? Canadian woman, so autistic woman. And advocacy groups, they prefer to avoid terms like disorder or high functioning or low functioning. And they prefer to use terms like neurotypical to describe people who are not neurodivergent, or to refer to non-autistic traits. And they prefer to use that versus normal. So words like disorder, low functioning, or high functioning, and words like normal are out. Words like neurotypical are preferred to refer to the opposite of neurodivergent, or the alternative, I suppose. And disability is a word that is used and embraced, but the notion of disability is seen through the biopsychosocial lens and involves society and the environment, and not just a problem within the individual. So it's important to consider from this lens, what we want to look at is look at the through the biopsychosocial lens that looks at biology, psychology, and society, and how they may manifest, how these factors may create mental health issues or difficulties for an individual. And neurodivergent individuals experience mental health issues, difficulty in social relationships, and struggle with school and work more than neurotypical individuals on average. And so I provided we were asked for this paper to provide an example case. So I took kind of a confluence of various individuals that I read about and that I worked with, and kind of put them into this case, this fictional character, this fictional client called Miranda, who's an autistic woman experiencing autistic burnout that's misdiagnosed as depression. So Miranda is a 38-year-old woman and mother of two seeking counseling for her low mood and extreme fatigue. And she has recently received diagnoses of ADHD and major depression and has started taking stimulant medication. And this has not fully improved her low energy. Her two small children are very active, and she often feels overwhelmed by her loud and busy home environment. She struggles to maintain her house and prepare and consume regular meals. And Miranda has dealt with anxiety for as long as she can remember. As a teenager, she was diagnosed with anorexia. She's always had difficulty making friends, and she was bullied throughout her school years. She enjoys spending quiet hours alone reading, and this is no longer possible with two small children. She's been staying up late, poring over information about ADHD, despite not really having time to be alone and read. And so she's bought several books about it. She's downloaded various podcasts to learn more. And she's joined many online groups, and she's perusing many online forums about ADHD. And she feels that the diagnosis explains her lifetime patterns of underachievement in school and at work. And as she's doing reading and being involved in the neurodivergent community, she's wondering if she might also be autistic. But her psychiatrist told her that she can't be autistic because she has friends, makes eye contact, and smiles when speaking. And this is in quotations. And Miranda wants to understand why she struggles so much more than others, and if there are tools that can help her manage her low energy and her low mood. And so I used this fictional case, rather than using stereotypes. This is just a confluence of many, especially women in my practice or adults that have been diagnosed with ADHD or autism later in life, and that are exploring this idea of neurodivergence and self-understanding, and often are experiencing difficulties with parenthood, with school, with work, with their social relationships. And they're starting to learn more about neurodivergence, and they're identifying with the characteristics. And now they're in the process of trying to understand themselves and understand their diagnoses. And in Canada, adult autism and ADHD assessments are conducted by psychologists and psychiatrists. Those are the only two professionals that can conduct an assessment. And only a few of these professionals work with autistic women and girls and understand the female phenotype. And in large Canadian cities like Toronto, it can take a year to access a publicly funded adult assessment. In small cities or towns, it may be impossible, it may not even be available. And private assessment can cost someone thousands of dollars. And so very often people go without a diagnosis, or they have a delayed or a misdiagnosis. And regarding autism, a delayed or misdiagnosis can cause individuals to attribute their symptoms to a moral failing, laziness, inadequacy, and it can increase the risk of depression and suicide. So rather than the person identifying with the identity of being an autistic individual, they're now thinking like, well, maybe I'm lazy. Maybe like, why am I having difficulties with work? Why do I have issues with the social environment that I'm in? Why do I always feel overwhelmed, in environments that other people seem to thrive in? Am I just an introvert, or is there something wrong with me? So people can start to internalize their symptoms because they don't have the self-understanding that can often come with the diagnosis. Even the process of diagnosis can facilitate an individual's self-understanding because you're working with a professional who can help guide you through the process of this entire identity frame shift that often occurs when we're understanding a new but very important kind of overarching aspect of our identity. So further consequences of delayed diagnosis or misdiagnosis are mistreatment opportunities or misdiagnosis. So somebody may be diagnosed with something else, like in Miranda's case, we're going to learn, and lack of understanding of the cause of their depression and anxiety, right? So somebody may think that they have a biological imbalance in their brain causing depression and not understand that it might be actually autistic burnout, just navigating a world that requires a lot more effort and energy to manage and to thrive in. And under treatment of eating disorders, which we'll talk about. So women who are not diagnosed with ADHD until adulthood are at an increased risk of depression, anxiety, sleep disorders, eating disorders, substance use disorders, and low self-esteem. And they experience more problems with parenting, work, and relationships. And incorrectly diagnosed neurodivergent individuals experience more shame and self-doubt because they're deprived of explanations for their differences, and they're also deprived of tools that may help them cope with a highly sensory, social, busy world. And so this is important. I have mixed opinions about labels. I think in some cases, and in many cases, these labels like ADHD and autism, because it's reflecting likely a biological genetic variation in somebody's ability to relate to the world, their cognitive abilities, their cognitive style. This might be a label that can foster an identity, that can connect you to community. It can help you understand, what coping mechanisms, what skills, what tools could be helpful for you, what environments may facilitate your mental health than others. Whereas with other labels, sometimes it can limit us, it can restrict us, it can remove our ability to display agency. So I think, but in many, many cases, like a label of like anxiety could be helpful to somebody because it helps to locate the problem. It gives the problem a name, and then that implies that there's a solution to the problem, right? So we always, as an ND, as a therapist in training, we always want to make sure that, and this is the work of Michael White from narrative therapy, is make sure that the problem, we're externalizing the problem from the person. People are not problems, problems are problems. When you externalize the problem, you're able to look at it, to work with it, to adjust it, to figure out, is it always a problem? Does it have some benefit? When do I want this thing? When do I not want it? You can turn it around, you can come up with solutions for it. If the problem's ingrained within you, then anything you do to try and shift it involves some sort of self-destruction, right? Some sort of denial of self and identity. And so a label like neurodivergence could be very helpful because now you understand an aspect of your identity, and then it can help us parse out problems that are separate from the identity. Okay, you're having a hard time maintaining consistent work. You keep getting fired. Let's break that down. Let's figure that out, right? It's not because, and maybe you're this label of autism is helping us understand why that might happen, when we can look at specific behaviors, specific environments, and try to help facilitate the adjustment between the individual and the environment. Now, in one article, so one researcher, Monique Botha, writes a lot about autism. She's an autistic researcher, and she writes a lot about neurodiversity in the literature. She writes a lot about the need for more neurodiverse voices to deliver firsthand experiences. She points out the problem that as she was getting her PhD, all of the resources, all of the literature she was looking at and researching was all from neurotypical individuals talking about neurodiverse individuals, and she felt very othered, very misunderstood. And so she talks a lot about this concept of minority stress, which was first introduced by Mayer in the early 2000s, and it's related to LGBTQ+ struggles, but it can be expanded to other minorities. Minority stress refers to the increased burden a socially disadvantaged or marginalized group faces that results in mental and physical challenges, physical health challenges. So it's interesting to note that 9 out of 10 stereotypes about autism are negative. Autistic individuals deal with victimization and discrimination, the expectation of rejection, internalized stigma, and burnout from masking symptoms to fit in with a neurotypical world. In Canada, we have some statistics that 31% of autistic adults rate their physical health as excellent or very good. And this is compared to 61% of adults without autism. So only 31% of autistic adults feel that they're in very good or excellent physical health. And 61% of neurotypical adults answer the same. So it's about half. Autistic women and men experience a 256%, so almost 3-time increase in all-cause mortality compared to non-autistic people. The increased mortality and reduced mental and physical health seen in autistic individuals are often thought to be a result of the disorder itself. So we look at things from a psychiatric lens. It's like, well, there's this difference and there's these outcomes, therefore it must be the difference causing the outcomes. It's very cause and effect. However, when you start to piece apart the different factors, social support rather than disability severity was more directly correlated with an autistic individual's quality of life. So if you provide a neurodivergent or autistic individual with the correct amount of social support, and then you see these mortality and physical and mental health deficits disappear, reduce. And so this is more of what we're talking about. We're saying, it's all about the environment, and that, the person, because they're situated within a neurotypical world, a highly sensory social world, the individual struggling with this minority stress is experiencing these negative mental and physical health outcomes. And this is worsened by blaming the negative health outcomes on the condition or the state or the individual, rather than this discrepancy between the environment and the individual and the individual's needs. Only 16% of neurodivergent adults rate their mental health as excellent or very good, compared to 70% of adults without autism. And so an author called Zenner, Canadian psychotherapist who writes about autism, wrote that anxiety occurs more often in individuals with high and above average intelligence and in women. So 2/3 of autistic women report having anxiety. And anxiety that autistic individuals face can result from the effort to adapt to a highly stimulating, interconnected society. So, for example, struggling to understand vague instructions, dealing with abrupt routine changes, and experiencing audiovisual sensory overload. 25% of autistic adults experience social anxiety, and you can understand that this is likely to be the case if you're misinterpreting social cues or having difficulty with social relationships or have a history of being bullied. And up to 50% experience depression, with females of a high to above average intelligence at higher risk. So being female and having high and above average intelligence may put someone at higher risk for mental health struggles. Certain autistic features, such as hyperfixation and mood swings, can be often misdiagnosed as bipolar disorder, and this can delay or miss a diagnosis. And you can imagine how bad that might be for the person who's now going down a route of medications that are geared towards bipolar disorder that can further affect dopamine pathways, can further stigmatize the individual, and it's just not the right treatment. And it's not even the right biochemical pathways involved in supporting someone's, social work, life goals. Autistic individuals with high or above average IQ have double the risk of addiction, and this might be because substances serve as coping strategies for anxiety, or they can often be ritualistic behaviors. And symptoms of obsessive compulsive disorder may also mimic symptoms of autism, and again, delay or mask a diagnosis, especially in adults and especially in female adults. So someone might be more likely to get an OCD diagnosis when they actually are autistic. And this might just be because of autism and an anxiety that's related to the trying to fit into the neurotypical world. There's much overlap between symptoms of borderline personality disorder and autism. So emotional dysregulation, feeling overwhelmed, especially in like highly stimulating environments. Individuals with BPD often have a history of trauma, and autistic individuals often have especially a social trauma history of being bullied, history of social rejection, inconsistent relationships, abandonment. So autistic individuals may be at risk for BPD due to environmental and social factors like social rejection or trauma. Suicide risk is really important to talk about. So autistic people have increased early mortality, and suicide is one of the leading causes of death for autistic individuals, especially those individuals who have high or high average intelligence. Suicide is often attributed to the condition of autism itself, even though 75% of autistic individuals have been victims of bullying. And we know that a history of trauma like bullying can be a risk for suicide. Suicide risk is highest in autistic women who are aged 35 to 64. And again, with high and above average intelligence. And risk factors include loneliness, lack of belonging, and a perceived sense of being a burden to society and others. And these are risk factors in general for suicidality, but may be more prevalent in people with autistic individuals who are, struggling again in their environment. Autistic individuals may also lack factors that decrease the risk of suicide. So these are like supportive factors like social support, helpful coping strategies, social and communication skills that you might need, you can imagine, to seek treatment and obtain help. Like, how do you navigate the healthcare system? How do you find a therapist? How do you connect with a therapist? How do you communicate? If you have alexithymia, how do you communicate what you're feeling? How do you get what you need? How do you articulate it? And so somebody who has a history or is in a situation with a lot of social isolation, loneliness, it may have difficulty in accessing help. Now, it's important to talk about certain features: masking, camouflaging, and neurotype dysphoria. So masking or camouflaging, these are I've seen used interchangeably. They characterize a neurodiverse individual's attempts to hide their symptoms to appear neurotypical. Sometimes this is done by copying the actions and mannerisms of a person or fictional TV character that seems well-liked and socially accepted. And so the autistic individual will, or even the individual with ADHD will sort of like look at the behaviors of the person and be like, okay, I'll just do that. I'll do that little smirk. I'll do that little laugh. And often there's like because of an attention to detail, an ability to really look between the lines, and pattern recognition capabilities, autistic individuals can mask really well. we talked about this and how this can often delay a diagnosis, especially women who may be more because who may feel the social deficits more heavily, may resort to masking or camouflaging in order to fit in order to, because the pain of social rejection is so terrible. But masking harms the autistic person's sense of self. It's associated with lower social well-being. It's associated with depression and suicide. And it's also associated with delayed or misdiagnosis, particularly in women. Very often, people with autism might not think I am autistic and it's difficult for me to be extroverted, so I'm just going to kind of smile and nod and make eye contact at this party. They might not know that they're autistic, and they may just feel like they may internalize their social deficits, feel like there's something wrong with them, and then wear a mask. And this may just further accentuate that feeling of social rejection and loneliness. Like, if people knew the real me, they wouldn't like me. There's a mainstream treatment for especially for children, and it's called applied behavioral analysis. And the neurodivergent community largely rejects this this therapy. The criticism of ABA, applied behavioral analysis, is that it's teaching children how to behave neurotypically through reinforcement. So when children display neurotypical behaviors, they are rewarded, and when they display neurodivergent behaviors, then they are, well, not necessarily punished, but they're just not rewarded. And so this is thought to encourage masking, to reinforce the idea that neurodivergent behaviors are pathological, that normal behaviors are preferred. It emphasizes the idea of normalcy. And so the neurodivergent community rejects this, and recognizing that things like masking harm a neurodivergent individual's mental health, they reject the idea. However, it's important to talk about this concept that was coined by a researcher called Chapman in 2020. And it's not a very prevalent term in the literature. It might gain more prevalence. It's in a Chapman writes about it in a couple of papers. One is like a Psychology Today paper, but another one is about neurodivergent-informed therapy, and they encourage counselors to understand this concept. Neurodivergent dysphoria is the term, and it names the phenomenon in which neurodivergent individuals may feel dysphoric identity. So they might wish to or identify with neurotypical traits, or they may set goals that appear at odds with their identity. So they might identify with the extroverted person at the party who's sort of the life of the party, and so maybe, you know, their neurotype dysphoria manifests as a desire to be more extroverted to gain social acceptance. And this is not wrong, but it's interesting and maybe helpful for an individual to understand this concept if they feel like, what is the difference between masking and accepting my identity, and how much should I try to fit in? And so to parse all of that out, like, and this is often done in therapy in general. It's like, who am I? What are my goals? What are my values? What are my traits? What are my gifts? What are my weaknesses as a person, as an individual? How does that line up with my environment, my social environment, my friends, my family, my boundaries? And often this is a process of discovery. And so having this concept of neurotype dysphoria can help us name something that that might be helpful to the individual, right? It's like, okay, so, this is sort of who you are, but there's a part of you that wants to be extroverted at a party. And so let's talk about that. What might be gained from that? Is that, what does that feel like? Do you feel like you're denying yourself? Do you feel bad about yourself? How's that affecting your self-esteem? How does that affect your anxiety? Maybe what we're talking about is a wish to reduce some social anxiety. So by understanding this concept, clinicians and even individuals can support their goals and support coping. And they can separate this idea from masking or camouflaging. And often when we name something, we have terms for things, it helps us work with it. Again, it helps the process of externalization. Autistic burnout is a phenomenon that can result from the prolonged stress of adapting to a neurotypical world. So it involves camouflaging, masking symptoms, working harder to compensate for feelings of inadequacy. Right? So this is very common in ADHD individuals who are diagnosed later in life, where they're like, I might be highly organized, like very perfectionistic, very on top of things, always sort of striving to maintain order because I fear, or I've been in situations where there has been total disorder. And so there's overcompensation, this fear of letting oneself go. And this requires a vast amount of energy and a vast amount of investment of resources. And this can often lead to burnout because, like in the case of Miranda, this feeling of having to work harder than everybody else. And a lack of interoceptive awareness, so this awareness of our body sensations and our emotions, may prevent a neurodiverse individual from being able to identify that this is happening. And this is pretty common. I think burnout can often lead to symptoms of major depression because we don't catch it. We feel ourselves kind of in that go, go, go state, which we call the resistance phase of the stress response. You have the alarm phase from an acute stress, you have the resistance phase, which is like you're treading water. And then at a certain point, you burn out. And when we're unaware of the amount of energy we're investing, or how exhausted we are, it's a risk factor for falling into burnout. And I actually have a burnout podcast you should check out. And so, the best prevention of burnout is to rest and support our own resilience before we get to the point. Like, you think of burnout as like a hole that we fall into. If we prevent ourselves from falling in, it's a lot easier to treat it. But if once we're in the hole, it can often involve more strategies, more time to fully recover. And so this is, this lack of interoceptive awareness, this alexithymia can prevent the autistic individual from really recognizing the burnout or how hard they're working. And autistic burnout may be diagnosed as depression. And, the problem I have with the diagnosis of depression in general is that depression is very often a state of stress hormone resistance, in which we have been anxious and overworking and striving or dealing with stress or difficulty for so long that our body and our nervous system finally collapses. And the way that depression is framed in the psychiatric model is that it's a brain imbalance that you were born with. And this just, again, it's like a misdiagnosis. It's like a diagnosis of bipolar. If someone's autistic, the solutions will not superimpose completely over the problem, right? So when someone's dealing with burnout, you want to really understand what the symptoms are, what they're dealing with, what their circumstances are, and provide support. So maybe support of our hormonal systems through herbs or nutrition. Maybe it's rest, advocacy at work, that the person can take a leave of absence, setting up expectations. Like, you're not going to take a week off and feel better. How can we make arrangements at work? How can we set boundaries? How can we facilitate? Should you be exercising or should you be resting? How do we navigate that? When the diagnosis is just depression, it's not honoring all of the different factors and considerations that make up those symptoms. And so misdiagnosis is a problem, especially if we internalize that problem to a biological brain imbalance, which is often how depression is framed. And I see that as a problem very often, where people are told that there's really no other solution than medication or cognitive behavior therapy, and that they're going to have this problem forever. And so it's just, we're labeling, we're conceptualizing the problem wrongly. And so, if somebody, you can imagine if somebody has a missed autism diagnosis, they don't have a diagnosis and they're dealing with autistic burnout, and then they get diagnosed with depression, they may feel like that might even further accentuate this idea of autistic, of something being wrong with them, right? And I will often hear the story of someone's depression. We always get into the story. If someone says they have depression, when did it start? How soon? What were the circumstances around the symptoms? How long did they last for, right? And often we don't have that. Often other people tell our stories for us. So you go through a really terrible time where you're depressed, and then you get a diagnosis and you're getting some sort of help and some sort of support. So that is positive. You're getting help from a psychiatrist. Maybe you're getting therapy. Maybe you're on a medication that is providing some benefit. And so the story that gets told for us is like, okay, I have this brain imbalance, I have this problem, I need this medication. And it can be empowering for some people, but more often than not, it's highly disempowering. And it removes these other important factors, like what was work like? What traumatizing loss did you experience a few months before? A lot of symptoms of autism. Perhaps you are neurodivergent, and maybe you're masking, and maybe looking at these patterns, looking at these other storylines, are really important for parsing out, the biopsychosocial factors of somebody's mental health and physical health. So that was a rant. I went off script. Trauma is often very prevalent in neurodivergent individuals' history. So very often they struggle to fit in. Growing up with an accumulation of unmet social and emotional needs can contribute to decreased self-esteem, poor mental health in autistic adults. 3 out of 4 autistic people have been bullied. Bullying is a regular occurrence for autistic children, particularly girls. And being a victim of bullying, we know, can lead to anxiety, depression, and self-harm, and can lower self-esteem. And girls and women with autism are more than 3 times more likely to be sexually assaulted than their neurotypical peers. It's very interesting to note, and I didn't really know where to put this in my paper, but I wanted to add a paragraph about eating disorders, because up to 30% of patients with eating disorders are autistic. And this I did not know. And this is such an important consideration in eating disorder treatment, in people. First of all, if a patient has an eating disorder, it may be worthwhile to have them assessed for autism or ADHD. But if 30% of patients in eating disorder clinics or diagnosed with eating disorders are autistic, this changes considerations for treatment. Because so first of all, many eating disorder treatment centers are group-based. And so if you are a neurodivergent individual, is being in a group with 70% neurotypical individuals and possibly a neurotypical counselor who is applying a neurotypical frame, neurotypical ideas, neurotypical environment to your condition, is that going to be the best healing environment for you? Are you going to feel the most accepted, the most understood? Or are you going to feel off, wrong? You're not necessarily going to respond well to therapy. If everyone's supposed to be sharing and describing their emotions and their internal feelings, is that going to be the best way for you to heal, right? So if we're missing this, if we're not aware of this massive overlap, like 30%, so about a third of people with eating disorders have autism or are autistic. So, and this might be because autistic individuals may have rigid eating behaviors, thoughts around food. There's characteristics like perfectionism, executive functioning issues, sensory processing challenges, altered proprioception and body awareness that may affect things like body image, ability to prepare food, consuming regular meals, intake of specific foods, and hunger and satiety cues. So there can be a lot around food for autistic individuals, right? So textures may be an issue, the executive functioning related to like meal prep and eating, and proprioception to understand that you're hungry, really hating certain foods, so restricting foods because of preference. So most eating disorder treatment is focused on body image, right? It's thought that body image is the central issue that leads to anorexia, for example. But with an autistic individual, that might not be the central issue. And so a treatment program that's focused mainly on body image may miss all these other factors. And maybe what would be really helpful is skill building to support executive functioning, to support meal prep or organizing meals. These other strategies that actually target the source of the problem. So this is a big area that requires probably more specific treatment, experts that understand how autism and eating disorders overlap, the factors involved, and really important considerations for someone who is autistic and has an eating disorder to look for treatment that may be geared to neurodivergent individuals. And then it's also important, I would say, for someone who's been diagnosed with an eating disorder to maybe get assessed for autism if you feel like there are symptoms or features that you identify with. So this is a big thing. And eating disorders, we know it's the most life-threatening mental health condition, and so it's not to be taken lightly. And we need individuals to get treatment, and treatment is usually involves very multifaceted approach, sometimes inpatient treatment, but very often a team-based approach where the family's involved. It's a big thing. Work is important to consider. So 86% of neurodivergent adults in Canada are underemployed or unemployed. So that is a massive number. In the Canadian Survey of Disability, only 33% of Canadian autistic adults report being employed, compared to 79% of adults without a disability. And this is despite being capable and highly qualified. There are many challenges that autistic workers may face, right? So social skills deficits can lead to social anxiety. It can alter tone of voice. Individuals may be more blunt. There may be features such as rigidity and hyperfixation that lead to poor relationships with work colleagues, or work colleagues don't understand them. Their work environments, especially corporate environments, they just may not be set up for neurodivergent individuals. There's often people need to be quite diplomatic. There's office politics that are often more important than work performance. And so these environments, and often the environment, like the lighting, the office structure, the temperament of your boss, all of these things can just be a really bad fit for a neurodivergent individual and lead to a lot of trauma related to work. If you're constantly very capable and passing interviews and getting work because you have a lot of skills, you're highly intelligent, and yet there's just this mismatch between the individual and their work environment that might be easily remedied if you're allowed to work from home, or if you're allowed to work in a team, or if people understand your communication style. All these things could be really easily fixed, but without an awareness, the individual ends up suffering. So information processing delays can interfere with the ability to prioritize, organize, plan, and initiate work, meet deadline. Information processing delays can interfere with the ability to understand verbal instructions. So often verbal instructions are just tossed out. You're expected to understand it right away. And autistic individuals or individuals with ADHD, that might just not be enough. How many times do you zone out, you miss what someone said, and it's I can't ask again. And then executive functioning challenges may be quite significant because we work in so many environments. We're expected to have high level of executive functioning that burns out the most dopamine driven individual with the highest executive functioning skills. So if you have impaired executive functioning, as many of us do, especially burnt out individuals, this can be a real challenge. It can lead to a lack of ability to prioritize, a lack of ability to organize, to plan, to initiate work, meet deadlines, lack of motivation, just lack of ability to concentrate, focus, complete tasks. And office environments can be loud, they can be bright, they can be filled with fragrances, lots of people walking around. Your desk might be open concept. And there may be a lot of sensory overload. And this can interfere with someone's performance and concentration. Just even having a fan above you, and that's your desk, and it won't be changed, could be the difference between being highly successful at your job and not being able to produce or be productive at all. And so a history of poor work performance can lead somebody to internalize the symptoms, just this sense of failure can accumulate within the individual, lead to low self-esteem. But in a lot of cases, this is what leads especially autistic women to seek help, and sometimes can lead to a diagnosis if they're like, I am just not doing well at work. I'm always losing my job. My boss never seems to like me. After a few of those experiences, people may luckily happen on a diagnosis to develop some self-understanding, and then better language, understanding, ability to advocate for what they need or what would work for them so they can perform to their potential, which is often very high. Or find a work that matches your cognitive abilities, cognitive style. So it's important to talk about something called neurodivergent-informed therapy. So a neurodivergent individual's problems are viewed in this lens of therapy, socially, relationally, and environmentally, and not as a result of the neurodivergence or disability. Okay, so this is very narrative therapy-like. The problem is the problem, not the person. So if the problem is I keep getting fired, then we'd look at that, right? Okay, what is wrong with work? What is going on? What have your bosses been like? What did they say? Look at all the different factors. Look at all the arrangements. Okay, the office, they always want you to come into the office. The office smells really bad. It gives you a headache, so what can we do? These are all very fixable problems, right? Neurodivergent informed therapists should validate neurodiversity, promote agency, relate to clients authentically, and encourage goal setting and skill building that supports the individual's well-being and social integration while acknowledging their neurodiverse identity. So this is from a number of papers. One is called Neurodivergent Informed Therapy by Chapa and Botha, 2022. And Hume, 2022, has a very interesting paper that we're going to talk about related to the therapeutic relationship. But first we'll talk about the diagnosis. So receiving a new diagnosis of ADHD or autism can result in a lot of emotions. And I've worked with many patients who have recently received a diagnosis who are kind of in the process of getting diagnosed, and it can be a lot. Like it is, even in the Enneagram community, which is not diagnostic, but it looks at like our personalities, right? Like even getting a personality assessment can create this frame shift for a person, because you see a side of yourself that until it was called out, labeled, articulated, just receded into your environment. And maybe other people labeled you as lazy, or like you just always thought you were bad at school. You didn't really understand why your grades were sometimes amazing and sometimes terrible. And it's like, am I smart or am I not smart? Or is it the school? Is the school suck? Did my teacher suck? What was in one class, I had to sit beside, the window, and there was like a cold breeze on me all the time. And there was someone behind me who was making noise, chewing gum. It's like, well, that's why I got a terrible mark in that class. So understanding getting this diagnosis can lead to a lot of emotions related to self-understanding. So people may experience relief. It's not me. It's not my fault. A sense of validation, right? Sometimes reading about yourself, you're like, holy, this is me. I've never felt so understood. You can feel shame. Like, what does this mean now that I have this label, this identity? Being different from people, confusion. What parts are the person I thought I was? What parts of this new me? Am I still who I thought I was? This identity shift can be very turbulent. Grief, mourning the old person, the person before the diagnosis. A sense of lost opportunities. If I'd known before, if I'd had the resources, the support, what would I have become? Would I have gotten different education? Would I have picked a different career? Maybe pride. I'm connecting to this community, they're understanding like these people who are part of the community that you identify with, that, there's certain gifts that this type of cognitive style gives me, or allows me, and sometimes shock, like sometimes you don't see it coming. So these are just some examples, but of course it could encompass any emotion. Holt and Langvik, they found that women diagnosed with ADHD as adults experienced a mixture of relief and hopelessness, which seems kind of counterintuitive, but again, it's these mixed emotions that can be very contradictory, very conflictual. So on the one hand, the diagnosis meant that symptoms weren't their fault, but the hopelessness resulted from feeling like certain things were outside of their control. If you're lazy, there's always the question, well, I could just stop being lazy. I could figure out what makes me lazy and stop. But if now, I'm understanding that this is how my brain gets energy, and if I don't have a solution right now, this is just who I am. And so, maybe now I don't call it lazy, but this lack of motivation, or this inconsistent motivation, or this difficulty with executive functioning, now I feel it less like it's not my fault, but also outside of my control. So like it's a weird place to be, right? So there may be relief there, but there may also be this sense of like, what can I do? Individuals may feel conflicted about informing work or school or social relationships, right? Especially considering that 9 out of 10 stereotypes about autism are negative. People may not want to just declare that label for fear of stigma. Many newly diagnosed neurodivergent individuals immerse themselves in research about their condition and are highly knowledgeable. And so very often my patients with ADHD, autism, like know way more about it than I do. They've like highly immersed themselves. They're experts. And so professionals working with neurodivergent individuals should be as informed as possible, but also understand that the client is the expert. And so if you are a client, if you're a patient, know that, feel free to inform your professionals about what you know, and also look for a professional that you feel good with, that you have a good fit with. But a marker of a good professional is someone who's curious and open to learning, and even if they may not know everything, is like kind of taking the resources that you're offering, checking them out. Like often patients will say, like, did you know about this group or this Instagram page? And so I'll check it out because I want to see what's out there that could be beneficial. Information can be packaged in really helpful ways. There can be social support online. Connecting with resources like Autism Ontario. There's a lot of resources there. This may support individuals in realizing their gifts, so such as sensitivity, spontaneity, creativity, rather than focusing on deficits. So really, looking not just at the deficit side, but like at the other side of like, what are my superpowers? Neurodiverse individuals may prefer online spaces for building community and connection. So the online world is a place where you can meet people, where you can connect with people, where you can feel understood, where you can share. It may feel easier to share online. Written word may be more helpful. And online support groups and communities can support belonging, and many people who are neurodivergent feel more comfortable in online spaces. Well, it's not necessarily like 100%. The inaccessibility of assessment may result in many neurodiverse individuals foregoing an official diagnosis. And so again, as mentioned, it's not the official diagnosis is not necessary to be part of the neurodivergent community, to identify as neurodivergent because you possess the characteristics, the features of ADHD, autism, or another neurodivergent condition. However, it may be worth pushing for diagnosis and official assessment if it allows you to access financial and social support that you might require, access disability services that could be beneficial, advocate for yourself at work for special needs, especially those like kind of easily remedied things that you might need support to implement depending on the work environment. But then also to support self-understanding. Like sometimes we may know that we are a certain way, but until we get the label of the official confirmation, we don't really accept or integrate that identity. And so it's totally up to the individual. So it's worth talking about the therapeutic relationship. And so very interesting that, and this is maybe more for therapists, for doctors, for professionals, but so there's a study that had structured interview with 17 autistic adults. So this is a qualitative study. It's very low percentage, like a low number of participants in this study, not like a quantitative, like scientific study. It's about it's like structured interviews mean like you're talking closely with the individuals in the study, and it's very narrative based. And often there's rich detail in the information, and you look at overlap, you look at patterns in the stories and in the information that's being accessed. And so it's one way to do research, and it can provide more individuality, more color, right? It's not just data, it's like there's story. And so in these interviews, 17 autistic adults were interviewed, and the theme of authenticity in the therapeutic relationship came up quite a bit. And participants all expressed that counselors and therapists needed to appear natural and not fake. And so this involved showing empathy without giving advice. And it was important to display affection and to accept the client by like making it clear that the therapist liked the client. And so there's many styles of therapy, right? Where like, it's more like the Freudian psychodynamic where like the therapist kind of removes themselves. They're not necessarily giving a lot of validation, like sort of the blank slate style. And so the individuals argued against that it was important for the therapist to like, not to be their friend, to still maintain therapeutic boundaries, but to show like the acceptance and like, and so you can imagine somebody who might have had a history of bullying, social rejection, having their social needs unfulfilled. It would be really healing to work with somebody who accepts you, who likes you, who validates your identity, your existence, who does nice things for you. And so that was so important, and who isn't fake, right? That you're not going to get the person sort of judging you silently while they're acting nice. And that was so important. So, and so, the empathy, the affection could be given through verbal expression, through acts of thoughtfulness or kindness. So like offering food was really helpful, considering the individual's like preferences. So like providing fidget toys, caring about like, dimming the lights, like remembering the person, bringing up their interests. 2/3 of individuals interviewed describe themselves as having high levels of something called affective empathy, which means that they could kind of sense and absorb the other person's emotions. So this is a feature of neurodivergence. And is it nature or nurture? Some argued that it was like just genetic, like they always had this, and others felt like their ability to detect these patterns in facial expression, gestures, tone of voice was a skill that they learned through studying neurotypical individuals' communication and social practices. But typically neurodivergent individuals have an ability to pattern recognize. So like noticing things in the environment that are not always salient to a neurotypical person. So like, oh, this gesture, this tone of voice, there's a mismatch there. That person's not authentic. Or you can pick up. And so this over time, when you develop enough of these data points, you put together this conceptual map of like being able to kind of absorb what somebody's feeling. And somebody who's dealt with social rejection is quite traumatic, especially to developing humans. And so when we are rejected socially, it's so painful that our entire psyche can be oriented to avoiding that from happening. And so this is where masking comes in, but this is also where effective empathy may come in. It's like, okay, I said that thing and that look occurred and then I was rejected. And so every time I see that look, I'm going to be really sensitive to any sort of cue that could predict my rejection or predict a negative reaction from somebody. And so being able to sort of like pick up, like train oneself to pick up on these cues was something that pretty high percentage, 2/3 of the individuals interviewed identified with. And so what this resulted in is that they were able to kind of pick up on the therapist's nonverbal cues. And then when those cues didn't match the therapist's explicit words or actions, they felt this sense of perturbance and like this phoniness and this disconnection. So any phoniness in tone of voice, demeanor, or dress was perceived as highly off-putting. And to a therapist, this might also feel like, you know, uncomfortable because you're being highly observed, and therefore it's like just letting down any pretext, like just being genuine, admitting mistakes, admitting we don't know, not lying is really important, because this mismatch between what your words are saying and what your body language is saying, you may not even be able to control or notice, may be picked up by the neurodivergent individual or neurodivergent client. And this resulted in autistic clients unilaterally terminating therapy. So just saying like, this is not a good fit. I don't like this therapist. They probably don't like me. And therefore I'm going to experience a painful rejection at some point down the line, or I'm just going to feel unaccepted. And so they would just not come back to therapy. Or, and this may even be worse, they would hide a part of themselves. So if they detected disapproval from the therapist, they would just stop expressing whatever it was that they thought earned them that disapproval. And so this is obviously to the detriment of the therapeutic relationship. And we know that therapeutic relationship predicts the majority of therapy outcomes, regardless of whatever type of therapy you do, whether it's CBT, whether it's trauma therapy. The therapeutic relationship is the glue that drives healing. It's the most important thing. And so prioritizing that is important. So finding an authentic therapist that somebody trusts, that you feel likes you, if you are neurodivergent, is should be high priority. Somebody that gets you, someone who's willing to learn, someone who's competent but also real. So there's often a lot of talk about self-disclosure, like should a therapist talk about themselves or disclose anything about themselves? And some people say nothing, 0%. But most, and obviously you shouldn't always talk about yourself, it's about the client. But there are different styles of therapy, and there's always room for some self-disclosure as long as it's conscious and in service of the client's healing journey. And so it's always an open question of how much is too much, how much is not enough. But the clients interviewed, they felt that self-disclosure was really helpful, that it supported the alliance, it made them trust the therapist more, it made the therapist feel more relatable, and maybe having the focus off them, even for brief moments, just help them feel more connected. And very often self-disclosure is used for normalization, I also struggle with this. And that sometimes that can be really helpful to a person who feels alone, or like they're the only one. Very often patients, clients will say like, have you ever heard someone say this before? And they might be the fourth person that day who said that exact thing. This is where support groups could be really helpful, because people can hear each other express experiences that we never express in daily life, and that we might feel like a giant weirdo for experiencing, that is super, super common. And so sometimes just a bit of self-disclosure of like, oh yeah, like you're the fourth person that said that to me today, or like, oh, I feel that all the time. That could be the difference between, somebody feeling totally alone and isolated and then feeling validated and normal, and, normal, I guess, in the general sense, but like feeling connected, feeling validated. Gestures of thoughtfulness, so remembering the person, being client-centered, being person-centered, remembering to turn the lights off to reduce sensory load, providing fidget toys. These are all noted and highly appreciated. And therapists could also should display affection for clients, maybe talking about special interests, incorporating them into metaphors. Metaphor is often very useful, especially for alexithymia, is using TV characters, using examples from literature, movies. And so if somebody's really interested, like special interests are like a feature of autism, where somebody's like really, really, really into something. And And so, really incorporating the special, okay, you're really like a huge Harry Potter fan. Well, remember the time that Harry, like, the metaphor of Dementors, or remember when Harry did this. And so we can like often describe emotions or describe complicated and abstract ideas using movies, using narrative, using TV. And so that was often very helpful for individuals who, lack interoception, have alexithymia. So agency is something that should be promoted with everybody, but it can be promoted in neurodivergent clients by emphasizing their identity, acknowledging personality strengths as well as weaknesses, and supporting desires, knowledge, and commitments. So what's important to you? What do you want out of life, or out of this therapeutic relationship, or out of coming to see me as a naturopath? What are you good at? What do you struggle with? What do you prefer? What's your preferred outcome? Where are you coming from? Where are you now? Where are you going? Where do you want to go? Clinicians should allow neurodiverse clients to determine their own therapeutic goals, right? So we don't look at the person and say, okay, you need to like be more social. We figure out, what are your goals? What do you want? What would be helpful for you? What would reduce your distress? What would help, what is the problem? Let's narrow down the problem as specific as possible so that we can solve it. So we can provide tools that'll help. And it's important to understand that some things may be problematic to the individual. Like there may be some features that you want help with, and others you might accept and embrace. And, like hyperfixation, special interest. Maybe these things are a source of purpose and joy, and you don't want, you're like, all I care about is, Harry Potter, and like, that's cool, and so the goal of therapy should not be to correct or normalize somebody, but okay, well, what do you want? Like what are your goals? Like, what does health mean to you? Like what would be ideal? So goals, it's good to spend a lot of time in goals, and so we'll talk often. Sometimes goals are implicit as an ND, but sometimes we really will like, what is your goal for this? Like, what would be a good outcome for you? Back to the concept of neurotype dysphoria, this concept may help us talk about goals, because sometimes goals are neurotypical, right? Sometimes it's like, well, I'm having problems at work and my boss is this way and I need to just be able to get along with her. It's like, okay, well, what could we do? So, I got to go to this, like, whatever it is or I have to be diplomatic, or she doesn't like me being blunt. So I have to swallow my tongue and just remember what I'm allowed to say. So sometimes there may be goals that undermine our identity. There's this compromise always, right? And so if that serves your values and your interests and your goals, maybe then we have this concept of neurotype dysphoria to talk about that. Many, even the most stringent neurodiversity advocates, they will acknowledge that there is usefulness in appearing more neurotypical as a practical coping strategy. Smiling and making eye contact in moments where you're like, I just don't want to deal with any negative vibes from people. Let me just, so when we're talking about masking, I think a big difference is even articulating it, highlighting agency and choice around it, maybe using this concept of neurotype dysphoria, like, when is it helpful? When do you want to do it? When do you not want to do it? And then this can also be done while affirming someone's identity as well, right? This is not something you have to do. Is this something that's worth doing? What happens if you don't do it? Is it worth this job? Do you have other options? Like, there's so many questions around this. So self-care is a big one, especially in an environment that might be more taxing. We're talking about burnout. So individuals with autism and ADHD suffering from sensory social overload or autism burnout may benefit from social and sensory withdrawal. And so this is a practice where you retreat to quiet rooms, draw a bath, turn off lights, or seek sensory comfort from pets, weighted blankets. All of these things can help recharge from the exhaustion of operating in neurotypical environments or recover from the emotional toll of masking. And so, this might be a daily practice. It might be something that you have to do on a weekly basis. This sometimes, especially if, like in the case of Miranda, right, a mother of two, trying to keep a job, wondering why she's having like lack of performance at work, just being able to know that this is a need can sometimes really help. Like, I need to just go to a dark room, lie with a bunch of cushions and the cat, and I need an hour or whatever it is, 20 minutes, and I need no one to come in. And this is something that my biology requires. And just in the same way someone needs exercise or water. And to be able to be able to know that can help us from feeling guilty, right? It's the whole, with self-care, the concept is you have to put the oxygen mask on yourself first before you help others. Another analogy is, I can't pour my cup into other people's cups if my cup is empty. And so self-care is not necessarily bubble baths, but it definitely can be. Self-care is, what do I need to do to recharge my battery? And without a fully charged battery, I can't help others. I can't serve others. I can't do my work in the world. So this is always a conversation I have, especially in our stressed out world. It's a very probably important topic to have with neurodivergent individuals. And if you're neurodivergent yourself, you might consider, like, what are your self-care practices? What makes you feel good? What recharges you? You might not know off the top of your head. You might have to do some thinking about this. Many people, it might be a hobby. It might not be. Some self-care is more involved, requires more energy to invest in. Like, I'm thinking of exercise or, outings and travel. These things are maybe more expensive, more time consuming, require an energy investment. Even if they do deliver an energy output, you might not have the energy investment, right? But others may not be. And sometimes just stepping outside and breathing in fresh air, or cool water on your face, or an animal. And I'm planning to do a polyvagal podcast. There are some polyvagal theory episodes that I have that you can search through. There's one on loneliness, and there's some interviews I've done with people on my podcast. So polyvagal theory is an interesting concept to understand the nervous system. So anything that kind of puts you in safe and social can help with nervous system regulation. And this could be, it's usually a combination of our sensory inputs: scent, sight, sound, touch, and taste even. And so often people who are experiencing sensory social overload just want to be alone in dark, quiet, like almost like sensory deprivation. And so lukewarm baths can actually be a really good strategy for that. Lukewarm salt baths. Sometimes I'll suggest things and we see if that works, but very often the best strategies are ones in which you come up with yourself. Individuals with ADHD particularly, they recognize that they experience better mood and executive functioning when they prioritize sleep, exercise, and general well-being. And often this is like a big chunk of the work we do in my naturopathic practice, is helping people with their routines. Routines are often really difficult to maintain, and very often they're all or nothing, and yet they are someone's lifeline to help with mood and executive functioning and wellness. So, did routines have to be like 90% of your day? Like, what are important? Often we focus on morning routines, getting food in, blood sugar, hydration. And there's tips, there's strategies. Working very closely with people, often strategies emerge. Skill building may be an important aspect of therapy. So Hervikoski found that dialectical behavior therapy tailored to ADHD involved participants' executive functioning. DBT, or dialectical behavior therapy, was developed by Marsha Linehan for borderline personality disorder. And it involves a lot of skills that help with emotional regulation, help with cognitive and executive functioning. So it's transferable to many more conditions than just BPD. So ADHD, there's been some benefit. People with depression, anxiety, it's been helpful because the emphasis is on emotional regulation, on skills, and so there are skills that are applicable and supportive, and then it's a group environment that could be really helpful in healing. And so it improved executive functioning. And individuals with ADHD, they benefit from support groups to meet and connect with other neurodivergent individuals and learn new tools. And this is like, sometimes just finding the community it is healing in and of itself. And so, yeah, so this is, where people can, like, when you're connecting with people, it's like you're finding commonalities, you're finding other people's tools, what's helpful. Like one person that I work with discovered a certain brand of headphones that do really well to block out sensory stimulation that have helped her ability to concentrate at work. So that's fantastic. And, with ADHD, slowly building habits that draw on strengths, aptitudes, and talents, and ensuring and celebrating success was vital. So it was like slow, building on strengths, just not imposing some sort of new habit, but like really slowly building habits. And there's a mindfulness-based cognitive therapy tool of acting with awareness, in which participants practice engaging fully in activities in the present moment. And this improved executive functioning. So you immerse you pay attention to what you're doing rather than kind of like distracting, zoning out while like kind of going through the motions and then losing that dopamine drive. It was like, I am breathing, I'm picking up a paper, I'm looking at it, I'm engaged in the moment. This was the best skill. So MBCT as a whole was helpful, but it was specifically acting with awareness, that skill, which you could Google because there are tools to help with learning that skill and exercises you can do. That was the most helpful for improving executive functioning. And metacognitive awareness, or the awareness of being aware, so like the being cognizant of your cognition, so thinking about thinking is another way of framing that, is a feature of executive functioning, and it can be improved through conscious practice, and it often is improved through Socratic or exploratory conversations. So I will ask, okay, so you procrastinate. Okay, so let's talk about the last time you had something due. What happened? And then we walk through, we parse out, we get to the, okay, and so what were you thinking about? Oh yeah, well, I actually realized I was thinking that if I sit down to do it, I don't know what the conclusion or the introduction is going to say, so I can't write it because I just stare at a blank piece of paper. I actually just had this conversation with somebody, and when she discovered that in the writing process, I was going to say most people, but I would just say in the writing process, what's often recommended is to write the introduction and conclusion at the end. That was like, oh, wow, whole frame shift. Oh, this can be done differently. So this metacognitive awareness allows us to understand what's the actual obstacle, right? Because often it's like a blank page. I'm just avoiding it and I just can't deal with this. And so the result is that I'm procrastinating or not doing it, or I'm waiting till the end where I feel the anxiety and the stimulation of stress and crunch time that now I'm motivated to do it. But when we can find, oh, okay, the blank page, not knowing what to write for the introduction, but you won't know what to write for the introduction until you've written your paper. So let's find a better place to start. That really helps. And this is sort of part of ADHD coaching. And so coaching that uses visuals, narratives, self-observations to identify internal distractions was helpful in neurodiverse clients that struggle to improve executive functioning skills. So internal distractions, like what is my mind, body doing that's distracting me? It's not like somebody like knocking at the door. Of course, that's going to distract us. What are the internal distractions that often escape our awareness? So developing metacognitive awareness through this exploratory questioning, through maybe like journaling, working on this ability to think about our thinking, to recognize our own mind, can help us identify what are the distractions, what are the obstacles, how do we work around them? And then we can be very specific with our interventions for building executive functioning skills. cognitive behavior therapy, so modified 8-week CBT, has been shown to reduce symptoms of social anxiety and improve mental health and social functioning in autistic individuals. So often we're looking at strategies to help with this, with the mental health conditions that may be associated with neurodivergence, but are not necessarily but are a result of the environment and how it interplays with neurodivergence, but not, and so the social anxiety may be something that we want to work on, right? That's not about working on autism. It's about, let's help the social anxiety. And so CBT could be helpful, and it was helpful in autistic individuals. And the researchers were concerned in their conclusion. They were like, our social skills are, they understand that these social skills interventions might pose a risk in increasing autistic individuals' camouflaging. Because a lot of the time social anxiety so CBT for social anxiety is largely about confronting the behavior you want to avoid, and dealing with the anxiety, the physical sensations and thoughts and emotions of anxiety that occur as you are in a social situation, and then thereby getting used to those sensations, and then they're not problematic anymore. And so the researchers were like, well, is this akin to masking or camouflaging, especially when we're talking about social skills? But what they found was if they provided a range of options, then people could use, so maybe eye contact is an option, maybe going, so there's maybe changing the subject. So there was just different social skills they offered. So you can use a tool that feels that you feel comfortable with, that gives you some options, that gives you a sense of agency and control. So you don't feel like you have to mask or hide yourself in order to complete the tasks. So it reduced this risk of kind of normalizing or pathologizing. Like we talked about, the use of metaphor, using special interests, they can help enhance social and communication skills, right? So like, remember in that episode of whatever show where so-and-so said this to so-and-so, that's kind of like this. And so using that, enhancing that, working with metaphor could be fantastic, especially in cases of alexithymia. And definitely you want to adjust pacing, use clear and concise communication, avoid confrontation, reduce stress. And then the sensory environment in therapy is really important. So allowing clients to make suggestions about what's better for them. How do you want the chairs arranged? Okay, is online therapy preferred? Do you want the camera on? How's the connection? How's the noise? Do you need different headphones? Do you need the lighting adjusted? Like, all of these things could be an obstacle to good therapy and could be very easily fixed. But if, maybe the client is scared to voice that this is a need they have. So allowing clients to kind of create their own space. Now, there's nutritional considerations too for, especially for ADHD. So there's certain nutrients that are helpful for supporting executive functioning, supporting brain function, supporting cognitive function. Omega-3 fatty acids are really important. Blood sugar regulation is absolutely important. And very often this has to do with really honing into specific strategies that will help somebody. Sometimes it's just like having a food that you just do in the morning, and it's like a recipe I recommend, and it has protein and it has fat, and you just eat it, and it's just kind of a chore, but that's important. And then recognizing why that's important could help motivate the individual. Understanding what hunger is, developing more proprioception, body awareness. I find that 4 p.m. snack is really helpful for executive functioning. It's often when we have a depletion of dopamine, depletion in blood sugar, our neurotransmitters are low, cortisol levels are low, and we just feel burnt out. And that's often when we crave sugar. It's often when we go for coffee. It's often when we feel like burnt out. And I've had patients having anxious moments, like panic attacks at that time. I've had patients feel depressed at that time quite significantly. And then we look at their day and we find the lunch was really sparse and they didn't have a good breakfast. And so their best meal was dinner. When they finally got a chance to sit down, it was often a late dinner, and maybe it was a dinner that they ordered out. But so maybe it wasn't the healthiest choice in the world, but it was a complete meal in that it had protein, it had fat, it had carbohydrates. And so then that's when the person felt their most energetic, was after dinner. And that sometimes can predict the like night productivity that can interfere with sleep. And so looking at someone's day and helping to just come up with strategies, right? So it's probably overwhelming and too much to ask for someone to do a whole day routine of breakfast, lunch, dinner. This is when you exercise. This is when your bedtime is. This is what, but that might be too many things. So sometimes we pick the most important thing and we start there. And so sometimes the process is very slow. But the good news is that when it comes to blood sugar regulation, sometimes just a meaningful habit change could just like a protein in the morning could be the difference between a good day and a bad day for an individual. And so this is something that we're doing a lot of nutrition coaching focused on that, looking at nutrients, right? What are ways in which we could make sure you're getting enough iron? Iron is really important for dopamine production. It's often deficient in individuals with ADHD. I'm very interested these days in iron regulation that requires copper and vitamin A. So it's not just about iron supplementation, but about how iron may be causing oxidative stress if it's not getting where it needs to go and doing the jobs it needs to do. And therefore, we need to help with the recycling metabolism. Beef liver is something that I would probably consider with people that need better, brain support, executive functioning support, because beef liver also is high in folate as well as copper and choline, which is a nutrient that supports cell membranes, helps with cognitive function, helps make acetylcholine, which is a kind of like a concentration, focus neurotransmitter. In one of my podcasts, we talk about folate methylation. This is often a really important factor, often in neurodivergent individuals undermethylate, which means they burn through neurotransmitters more quickly. So your brain loses energy. And so you need, and this is a feature of executive dysfunction, is you need to be stimulated in order to be motivated. So this is why we might be able to perform at crunch time, but if you have something due a week from now, it's hard to get motivated until you have those stress chemicals in your system. So supporting dopamine production, supporting neurotransmitter production can help stabilize mood. This is done through blood sugar regulation. It's done through honoring methylation, so beef liver, B complex. Zinc is really important. There's a condition called pyroluria, in which red blood cells accumulate these things called pyrroles that are depleted and reduced with B6 and zinc. And so individuals have a much higher need for vitamin B6 and zinc, and often feel like their brains are much clearer and that their anxiety is gone if they're on top of that supplement regime. Magnesium is always important for energy levels. And then we're also looking at just like physical comorbid conditions, like how is gut health? How is hormonal health? How's your mental health? Like, are there any other conditions you're dealing with? What are the signs? So really in like a naturopathic intake, we're looking deeply at the specific features of somebody's case. Again, the biological, the psychological, the social. But these are just some considerations. Supplementation could have a huge effect. And looking at inflammation, food sensitivities, that might be relevant. Fungal infections, dysbiosis, gut infections could be majorly important. Inflammation might be a feature. And, when it comes, this concept of nutritional genomics is we all have genes that thrive in certain environments, but we're all living now in this specific modern environment. And this kind of fits with the neurodivergence movement, is when our genes and our environment are at a mismatch, this creates disease, this creates difficulty, this creates mental health issues, physical health issues. And sometimes supplementation supports our genes. This is the idea of nutritional genomics. It's like maybe my genes mean I need to supplement B vitamins or beef liver or something like that. If you want a more, maybe my ancestors all consumed tons of liver, and now because I live in a society where we don't consume liver, I am deficient in folate and choline and all these things that I need more of. And so supplementing can help. And we live in an environment where there is a lack of magnesium, and the increased stress of our environment and the demands and the requirement for high executive functioning burns our magnesium resources more quickly. And so we are in an environment where we have a lack of magnesium and an increase in magnesium burn rate, and therefore supplementation may be required. or it's important to focus on foods that have high magnesium. So there's these considerations that are helping us adjust our environment, our nutritional environment, to support our specific genes, needs, biochemical individuality. And so, when we're looking at neurodivergence, considering that it's a genetic, a genetic state, genetically determined, there may be certain SNPs and nutritional considerations that are also genetic that are overlapping. And of course, we're looking at environmental mismatch, right? Is your work environment just not conducive to your cognitive style, to the way that you work? Do you work better at nighttime? So how can we advocate? How can we help your environment fit you better so you can thrive? So what we're curious about for the future is for more conversations from neurodiverse people in research and clinical spaces, like to understand more the neurodivergent mind's specific needs, parsing apart the social determinants of health from the individual's unique needs, right? So we see, okay, there's an increased risk of suicide, but if you provide social support to the individual, then this risk of suicide decreases. So how can we provide the proper amount of social support? How can individuals access social support? Historically, there's been a lack of neurodivergent voices in the research, and it was Botha writes that in her PhD studies, it was like her opinion or lived experience was somehow considered invalid because it was like it wasn't objective. And she argues that objectivity is about objectivity is impossible. True objectivity, because we're all humans and we all come at things with a certain bias. And so what we should strive for is rigor and peer review, and that will provide allow us to access truth. And we need to have different voices lending their experience so we can understand. And interestingly, the conversation has a lot of the time been focused on so in the neurodivergent community, in the autistic community, there's less of an interest in the cause of autism, because it is considered just a biological variability, right? So it's not like, how can I have a baby with red hair? It's like, that's just not really possible. It's just genetically determined that your baby will have red hair. You can't change that or prevent that. And there's nothing wrong with red hair anyways. And so let's just accept that this is a biological variability and that it's beautiful, and let's support the well-being of the individuals, as opposed services, interventions, accommodation, acceptance, rather than questions around prevention, cure that we would consider for diseases. And so there's a big movement away from that. So autistic-led research is more likely going to focus on how do we support the individual versus the medical model version of prevention, cure, disease model. And so this is an argument for individuals within a community conducting their own research, being a participant in clinical considerations. And then we also want to consider, how neurodivergent-led therapy or neurodivergent therapy groups would be helpful for treatment fidelity, for treatment response, especially in conditions like eating disorders, where a high percentage of individuals with the condition are neurodivergent. So would it be appropriate to have eating disorder support groups for neurodivergent individuals, or eating disorder prevention for neurodivergent people? What are the considerations? How do we work with that overlap? And so, it's in conclusion, we want to understand, that there is neurodiversity, that we are all diverse human beings, and that at least 15% of us have a different style in the way we relate socially and cognitively with the world. And this, previously, historically, has been recognized as a divergence from the norm. And now we're recognizing this is just biological diversity. And there are specific challenges that somebody with this type of diversity faces, and there are increased risks, suicide, depression, anxiety, that are likely from these external factors that might be related to trauma, bullying, difficulties with work, underemployment, unemployment. There's an increased likelihood of social trauma, especially bullying, and there's consequences of delayed and misdiagnosis, and this internalization of symptoms to personal or moral failings as opposed to someone's neurodivergence. And so, understanding minority stress, understanding concepts of masking, camouflaging, autistic burnout may be helpful. And, identity first language is important, authenticity, and working specifically with an individual's goals, skill building, executive functioning might be a very important thing to talk about. Working with burnout, preventing burnout might be really important. This idea of neurotype dysphoria might be helpful. Identifying other comorbid or understanding comorbid conditions or mental health conditions that might be someone might be experiencing, such as eating disorders, social anxiety, and learning from neurodiverse individuals. So that was my presentation. Let me know if you have any questions. Hopefully that was helpful or at least informative. Yeah, let me know if there's other things I should have included, if there's other things I should have considered, any questions you have for me. And if you need references, let me know. But thank you for listening.